Muy bien, enseguida vamos a darle la bienvenida al doctor André Abreu, que viene con una ponencia magistral sobre biopsia por fusión, nuevo estándar en el diagnóstico del cáncer de próstata.
Good evening. I'm André Abreu from USC Urology, Los Angeles. Sou brasiliano, então entendo pouco espanhol, entendo pouco portunhol. Depois, se tivermos algumas perguntas, podemos discutir. Para la talk, prefiro hablar in English, please. It's easier for me. Okay, thank you. Thank you so much. The Centro de Urologia Avançada do Nordeste, thank you, Dr. Sotelo, Dr. Galan, for the chance and opportunity to be here and talking to you. So I will talk about MRI ultrasound fusion biopsy and where we stand today within this technique. There are two ways to perform prostate biopsy for diagnosis of prostate cancer. One is performing the 12-course systematic biopsy. The other one is perform MRI and then MRI informed or MRI fusion or biopsia fusionada target biopsy. The problem with systematic biopsy is because systematic biopsy may miss significant cancers by random errors, may miss significant cancers by systemic errors, and may detect insignificant cancers or may misclassify significant cancers. So in the past few years, the MRI of the prostate has been involved. Initially, it was used for staging pre-prostatectomy or pre-radiation. Afterwards, it was start utilizing the MRIs for localization and of suspicious lesions for biopsy. And lately, it's been used even for risk stratification as a biomarker, like a PSA, like any other biomarker. Now, what are the outcomes of conventional biopsy versus MRI transfusion biopsy? I selected a few manuscripts. The literature is vast. There are a lot of literature there. I will talk about a few of them. This is probably one of the most important manuscripts that was published in 2015 in JAMA from Dr. Pinto from NIH. They did an MRI, and then two operators did, one of the operators did MRI target biopsy, the other one did systematic biopsy. The one doing systematic biopsy was blind to the MRI, did not know the results of the MRI. It's of note that vast majority of these patients had prior biopsy. Reason for this is because at that time, the MRI was not available, was not approved by the insurance, and most of these patients had to have a prior biopsy, then the insurance would authorize the MRI. So the results were MRI ultrasound fusion biopsy detects 30% more high-risk cancer and 17% less low-risk cancer than the conventional biopsy. Now, another paper that came out, this is a multi-institutional manuscript from Europe and US, that they randomized 500 patients in 23 centers. Patients were randomized for MRI versus no MRI. Patients with no MRI underwent systematic biopsy. Patients with MRI, if they had MRI negative, they did not undergo biopsy. If they had a lesion, they underwent biopsy target only, no systematic biopsy, okay? The results were clinically significant cancer was higher with the target biopsy group, and clinically insignificant cancer was lower for MRI biopsy group. And then a meta-analysis that put together 15,000 patients that was published. This meta-analysis was published in 2019, but the analysis was made up to 2018, 15,000 patients. And what they found was clinically significant cancer detection was in favor of MRI ultrasound fusion biopsy. clinically insignificant cancer detection was in favor of MRI fusion biopsy, meaning that the MRI fusion biopsy detects less insignificant cancer and more significant cancer. Then another systematic biopsy came published in August of 2019, and this systematic biopsy has really strong outcomes. The results of MRI-informed or MRI-target biopsy strategy in patients with first biopsy, okay? Prostate-naive patients. What they show was there is a significant higher diagnosis of any clinically significant and high-grade prostate cancer compared to the standard biopsy. This is very strong. Not only this, when we exclude systematic biopsy from the target biopsy, still target biopsy was associated with decreased rates of clinically insignificant cancer detection and not affecting clinically significant cancer detection or high-grade cancer detection. This is very strong. If this is indeed truth, I myself, this is published in Journal of Urology, reported authors, but if this is indeed true, we do not need to perform systematic biopsy. This is not what I think, and the reason is, when we look at other manuscripts, we see this. This is a paper from France, 2050 men in 16 centers. So what they did, 12 core systematic biopsy. The two operators, one operator during systematic biopsy did not know the results of the MRI. The other operator performed 3 cores target biopsy, okay? Same patient. It's different from that manuscript from New England. We had 2 different patients. Although the patients were randomized, they were different patients. Now we are talking about the same prostate, same patient, same prostate. And what they found was systematic biopsy detected 30% of the cancer, target biopsy 32% of significant cancer, no difference. Then target biopsy adds 7% to systematic biopsy, and systematic biopsy adds 5% to target biopsy. So cancer detection rate is 37%. And as we can see here, systematic biopsy still play a role. Systematic biopsy still improving cancer detection rate. But the problem with when we do systematic biopsy is that we pick up a lot of Gleason 6, many more, 20% versus 6% when we do target biopsy only. So my reading for this is systematic biopsy is still important, and I'm not sure we can just perform target biopsy. Now, when we looked at the same cohort, and they look only for high-grade cancer, Gleason 4+3 or higher, then target biopsy is better than systematic biopsy. Similar results from the first manuscript that I showed from JAMA. Now, patients that do an MRI and the MRI is negative, can we just avoid biopsy, skip biopsy on these patients? To answer this question, we need to look at the negative predict value of MRI. Now, this manuscript's PROMISE trial was published in Lancet 2017 as a multi-center study, almost 600 patients. The design of this manuscript is the best design to answer this question. Why? They did transperineal mapping biopsy, taking cores of the prostate every 5 millimeters, like 50, 70, 100 cores from the prostate. On top of this, they did ultrasound, 12-core systematic biopsy, and MRI. So this is as close as you can get for a prostatectomy, right? So unfortunately, we do not do prostatectomy for benign disease to answer the question with the gold standard, meaning negative MRI, do prostatectomy, and see if there is cancer there or not. But this design of this manuscript is very good. What they found was negative predictive value of the MRI is 76% for Gleason 7 or higher. That means if the MRI is negative, you still have around 25% of the patients that will have clinically significant cancer. Anyways, if you do MRI as a triage, you can avoid biopsy in 25% of the patients. There are several authors and experts that advocate if you have a negative MRI, you do not do biopsy. This is mostly thought from Europe. In US, overall, we don't think like this. Before, what I could tell in advice is, before you go and avoid biopsies for negative MRI, I think you should know first, upfront, the negative predictive value of your center. Your radiologist is different, your MRI is different, you are different from Europe, so from European urologists. So before you just avoid biopsy, know what we are dealing with. So we look into our data, and what we find, this is our data from USC, we found that negative predictive value of the MRI at USC is 82%. And when we combine with the PSA density, we see that the negative predictive value of the MRI improve up to 100% with the decreasing of PSA density. Which patients are these patients? These patients here are patients that have BPH. They have a very large prostate. They have high PSA, 10, 11, 12, whatever, with negative MRI. And people keep biopsying these patients. Stop biopsying, do something for them, but stop biopsying. These patients do not have cancer. If they have these three combinations, negative MRI, PSA density less than 1.5, and history of prior negative biopsies, none of these patients have clinically significant cancer. Now, to summarize, MRI-derived or MRI transfusion biopsy has higher detection of significant prostate cancer, especially for higher risk patients. It has lower detection of insignificant cancer. Prostate biopsy can be avoided in selected men with negative MRI. Now, the take-home message from me is, and that's what is from the guidelines, I'll talk about the guidelines next, is if your patient has indication for biopsy, and this supported by the guidelines and AUA policy, do MRI first. If the MRI shows suspicious lesion, then you do MRI ultrasound fusion biopsy, target biopsy plus systematic. We are not at the level that we can avoid systematic biopsy yet. For selected patients, maybe, but not overall. If there is no lesion on MRI, and the patient has a strong history or strong clinical suspicions for cancer, then you do systematic biopsy. If the patient does not have a strong suspicion for cancer, then you may avoid biopsy. Now, this is supported by the UK, England, United Kingdom guidelines. Multiparametric MRI up first as first line in the investigation. Is supported by the European Urology guidelines that was updated in March of 2019. Recommendation in biopsy-naive patients perform MRI before prostate biopsy. Recommendations in patients with prior negative biopsy perform MRI before prostate biopsy. So these are the recommendations from the guidelines. Now, this is not a guideline. This is published on Journal of Urology, October of 2019, from very reputed authors, putting together AUA and the American Radiology Society as well. What they say is MRI, you should offer MRI for men with prior negative biopsies. This is not new, that was published before. But what is new from the AUA, this is the AUA policy, is that now there is sufficient data to recommend MRI prior to biopsy for all men. So this is not AUA guideline yet, but this is the policy from the AUA, and this will soon be the AUA guideline. So now, what are the concerns for the MRI? This is a editorial comment for European Urology. This is my opinion. These are my thoughts. And if you are doing an MRI for prostate cancer diagnosis, we need quality. We need quality. We need reproducibility. We need accessibility. The patient should have, if you are recommending to do MRI for every single patient, we should provide a way for them to go to have this MRI. And this should be cost effectiveness. MRI is costly. And urologists, pathologists, and radiologists should have appropriate training. Now, let me address just a few of these limitations. Expertise. Your radiologist should read at least very minimal 50 MRI per year. At least. That means one MRI per week. if your radiologist is not familiar with MRIs, your MRI will be poor. And your radiologist should regular attend meetings. The radiologists are sitting in the dark room, just saying there is a Pirates 3, 4, 5, and this and this and that, and they never see the results of what they are doing. They never see the histology of the MRIs that they are reporting. So the radiologist should get out of their room and go and see what is going on with their reports. At USC, we have twice a month an MRI fusion biopsy tumor board that we discuss our MRIs and the biopsies with Dr. Palmer as our senior radiologist and Dr. Manduero as our uropathologist. So this is very educational. We learn a lot. If you do, you see how much all of us learn from each other. Now, we know that MRI is operator dependent. So to improve interobservable variability, we have to reduce operator dependence. One way to do this, and this is a study from our group, is to do automated reading, machine learning, artificial intelligence, radiomics. This will improve and decrease, it will improve the MRI report and decrease the interobservable variability. Accessibility. Again, MRI is costly, yes. However, when you look at the CT scan, this is New England Journal, they say lung cancer screening with low-dose CT. This is a screening, like PSA. It's not for diagnosis of somebody that is suspicious, it's for screening. I'm not saying we should do MRI for screening, although there are trials on it. However, if we look at the biparametric MRI, that has all the same parameters as the multiparametric MRI, however, there is no contrast, it may shorten the time of the MRI and lower the cost. Contrast is the less important parameter of the multiparametric MRI. So when we look on multiparametric MRI, 1,000 patients, low suspicious biparametric MRI has high negative predictive value, ruling out clinically significant cancer. Not only this, this group, this is Dr. Jelly Barents from Netherlands, that's a very well-known group. They created what they call the FAST MRI, which is a protocol that does not use contrast. The patients stay inside of the MRI machine for 12 minutes only. If you do with contrast, usually the patients stay inside of the MRI machine for 45 minutes. Now, with this FAST protocol that they created, they actually found no difference in terms of cancer detection rate on biopsy afterwards. So, again, short MRI protocol can improve prostate MRI accessibility and lower the costs. Now, what you're seeing here is office-based MRI. This is an MRI. This is your office. Instead of you having an ultrasound machine sitting on your office, this is an office-based MRI. The patient is lying down here in lithotomy position. The perineum is attached to the MRI, and you will do MRI office-based in the future. Now, costs. Costs are very important, of course. There is no way that we do MRI and biopsy be cheaper than just going and doing biopsy. Of course not. However, if we think in terms of cost effectiveness, then the MRI biopsy pathway can be more cost effective. How? To avoid biopsy in some patients that don't need, avoid rebiopsy, decreasing overdiagnosis and overtreatment, specific protocols, as we discussed, to decrease time, cost, and having similar outcomes. So, how about time? To do an MRI fusion biopsy, the patient has to go to the MRI. After this, they have to go biopsy. Sometimes, or most of the times, this happens in 2 visits. So it's time for the patient, it's money for the patient, for the system, for the insurance. So what we created at USC, this is our data, was a protocol because we have patients coming from several parts of the world, literally. So we created a protocol that the patients come and they do one-stop MRI biopsy. The patient comes to USC, he does the MRI 7 a.m., the radiologist does the report for me, 10 o'clock, 11 o'clock, I do the biopsy, the patient go home the same day. So instead of coming for MRI, go home, come back for biopsy, the patient does the MRI, cross from bureau to the other, I do the biopsy, and they go home. And the results are the same. Here are our results. We see PARIDS 3 is 30%, PARIDS 4 is 60%, PARIDS 5 is approaching 85% when we put all the patients together. As anything in the world, from the beginning, what is new, innovation, they are more expensive. However, with the time, it becomes cheaper. Just to give you an example, in 1947, for somebody to go from Sydney to London, they would do 1, 2, 3, 4, 5, 6, 7 stops, right? That would take 55 hours in the air and 4 days to go from Sydney to London. Now, in 2018, they go from Sydney to London in non-stop flight, 17 hours, 1 day journey. Not only this, it cost 20% of the entire cost that was in 1950. So as anything, MRI will be more accessible and will be more cost effective. So based on this, don't wait so much to do the MRI for your patient. Do the MRI up front, otherwise they may have some metastasis. Thank you. Any questions? No?
Promedio para poder hacer una resonancia sin contraste y poder establecer perfectamente los p-RADs. Porque en México tenemos ese problema. O sea, tú mandas a hacer una resonancia en diferentes partes y es un verdadero problema para el urólogo, porque cada quien te pone la imagen que quiere y si acaso te llegan a dar los p-RADs, pero generalmente no te los dan.
I totally agree. And I put on that editorial for the European Urology, quality. If you do not do a good quality upfront MRI, just don't do it. Yeah. You just will create problem. Because the radiology will misread, and they will say there is a PARIDS 4 or 5. Sometimes I face this. Patients come with a PARIDS 5, and they say, I don't see PARIDS 5 here. I talk to my radiologist, André, you know, it could be PARIDS 3. But for the patient, he is very concerned. And when they see the results of PARIDS 5 was supposed to have 80% chance of having cancer, then they say, you know, you missed the target. I totally agree with you. The radiologists, again, they should get out of their dark rooms. They should hang out with pathologists and neurologists. They should know what they are reporting. They should know the results of their report. They should follow the protocols, the PARIDS consensus, the PARIDS, the way it's written, that is very clear. It's very easy. You download it free. It's very easy to report. And answer your question, how many MRIs a radiologist should do? At least bare minimum 50 per year. But I would say it's too minimal. Yeah. 50 per year is 1 per week. Yeah. It has to be more and more. There are some manuscripts assessing these numbers. The more they do, the better, of course.
Okay. Gracias.
Okay, muchas gracias. No questions? Okay. Gracias.
Muchas gracias, doctor Abreu. A continuación tendremos la inauguración y el cóctel de bienvenida que está programado a las 20 horas, así que los invitamos a permanecer aquí, tomar algo para acompañar a hacer la inauguración formal y posteriormente invitarlos a un cóctel en el salón aquí de al lado que está en Los Cristales, con todo gusto. Entonces nos vemos en en un ratito más para hacer la inauguración formal del curso. Gracias a todos.